I haven't had the opportunity yet to greet you. So I would like to say congratulations to all of you on your inauguration of your Dietetic Association. We are definitely looking forward to continue working together with you, and we are excited to see the great things that all of you will be accomplishing. And when Jesse, Karen, and I were talking about what I'm supposed to talk about this afternoon, we had decided that I was going to talk about diabetes. But when our Romanian boss, Dr. Dan, looked at what we had decided, he said, no, you know, I think it would be a better idea to do a case study. So I thought, oh, okay, that sounds really good, because you all know about diabetes already, and so we will go on with a case study. And the case study that I will be presenting to you is actually a patient that one of my students saw last year. Now, this is a little background information on our curriculum back at Loma. Before our students go on their clinical supervised practice, we just don't throw them out into the lion's den. We like to gently hold their hands and help them take baby steps. And so before they go on their first clinical rotation, during the time that they are taking Medical Nutrition Therapy 1, we actually do some role playing and practice nutritional assessments in the classroom. And then by the 3rd or 4th week, I've been getting them ready, getting their courage to get up. I start taking them to the medical center once a week, and we actually start seeing patients. So that's our simulation. In addition to the role playing that we have with each other, they actually practice on real patients. And it's really a scary time for some of them because this is their first time talking to patients. But I walk through the whole process with them. I do see the patients together with them. And so as we send them off to their clinical rotation, they are assigned that when they are on their rotation, they are supposed to find a patient of their choice in which they find that particular disease process that they're interested in one of the patients at the hospital that they will be at. And by the time they come back to us at the end of the summer, they're supposed to present to us a thick booklet that they have produced themselves that has to do with the patient that they have seen. And so I have the privilege of grading all of them, and I actually enjoy reading them because it's very fascinating what I find. And so the one that I have chosen today is on, oh, where's the little, oh, is this the clicker that makes it go forward or backward, or not, or maybe not? Just use the keyboard? Okay, I'll just use the keyboard. Okay. So the case study that I chose is on diabetic ketoacidosis. And so for a quick review, I would like one of you to tell me in a brief, short sentence, what is diabetic ketoacidosis? Not everybody speak all at once. Yeah. I know you're dying to tell me. I'm sure Maria would like to tell me what DKA is. She said it's a person who has diabetes. Okay, but that's a good start. That's a good start. That's true. Okay, well, you know what? As we go along, we'll have a better picture of what it is, but really quickly. No problem. Not a problem. I know you do. So really quickly, before we go on this case study, diabetic ketoacidosis is when, okay, blood sugars are high and either insulin, not enough insulin is being given to bring down the blood sugars, or there are times that, you know what, the patient or the person has forgotten to give themselves insulin, and sometimes they've run out, sometimes their resources hasn't allowed them to actually get additional insulin. So that's a few of the reasons, and sometimes it's because they have an infection that has really made the other metabolic processes become more enhanced. So those are just a couple of the reasons. But let's go on to my patient, or not my patient, but the patient. So the patient is a 38-year-old female, and her admit diagnosis is DKA, or diabetic ketoacidosis, and they also diagnosed her at the beginning with acute renal insufficiency. And her chief complaints coming into the hospital was that she was having pain in her abdomen, she was nauseated, she was vomiting when she came in. And so this might be triggering for you now, giving you a clearer picture of what diabetic ketoacidosis is. And then her past medical history is that when she was 16 years old, she was diagnosed with type 1 diabetes. She has a history of hypercholesterolemia, and what is that? Is that high cholesterol or low cholesterol? Excellent. And she also has a history of hypertension. Does this one work too? Oh, how nice. I can go either way. But she hasn't had any surgeries in the past. Her height is 165.1 centimeters, or she's about 5'5". Not too tall, but definitely taller than me. And her admit weight was 65.4, and she left the hospital at 65.6. So her weight remained the same practically. She was actually admitted on July 26, and she was diagnosed on August 1. Okay, so her ideal body weight, according to using the Hamwe method, is 56.8 kilograms. And are you all familiar with using the Hamwe method of figuring out ideal body weight? Kind of, sort of? Well, we'll go over that on Friday, okay? So her percent ideal body weight is 114%, and her BMI is 24. Is that a normal body weight, or is she underweight, or is she overweight? Just normal. Very good. Fantastic. Okay, so then she is black. She is a paralegal by profession, and she is married with 2 young children. And her other family responsibilities is that she is a provider for her family. And she does cook dinner, but just about 3 to 4 times a week. Her husband will help out occasionally. However, her family goes out to eat a lot. In addition to all that, she is very active in her daughter's academic and extracurricular activities. So there's a lot of activity that's going on. She is really doing an excellent job of being mother. And she claims that there are no marital or family problems, but really who would admit that to their dietitian, as they are talking to them anyway. And the home environment, though, is that she is from an upper middle class economic status. Her family is usually happy, and although she does have a few disagreements with her young daughters, and that's understandable, that's definitely normal, comes with the territory. So in addition, this patient, her health habits and her mental attitude is that she claims that she tries to keep her blood glucose levels within normal range. Now, when a patient says that, when you hear them say that, wow, that sounds really positive, like they're really trying to do their best. And then there are some other patients, when they say that, it's actually like, well, I try whenever I can, if I think about it. So it's kind of hard to say, to actually assess at first when you're hearing this, until you keep talking to your patient. But then she says, but then she just gets so caught up in work and her busy life. But then she claims, but I wish to be more conscientious of her health status. So she'll interject that in there as the interview goes on, as the dietitian and the student dietitian were interviewing this patient. Now keep in mind, this is an inpatient. This patient was interviewed in the hospital. She does claim that one of her issues, one of her problems, though, is that it is very hard to get from her family members, her 2 daughters, and from her husband, the support that she needs to eat healthy. So that's a barrier that can make it difficult for someone to really follow the path of living a healthy life when the rest of your family members are just not wanting to do the same as you or to even support you. But then again, she has expressed a strong desire to build a healthier lifestyle. And you know, especially when you're in the hospital because you're not feeling good, you're nauseated, you're throwing up, you're having abdominal pain. Sometimes when you hit bottom after a while, sometimes that wakes a person up to say, I really want to change and take charge. Her religion, she's non-denominational. She does not smoke. That's one good thing she's doing. And she doesn't drink any alcohol and doesn't take any drugs. So her usual eating pattern at home or at breakfast, she claims that she eats breakfast around 6 o'clock in the morning. She consumes a cereal and has coffee most days of the week. And that's if time allows. That's if she has time to eat cereal. But when it comes to her coffee, she says that she does have that every morning. So as a dietitian, you're already thinking, wow, we've got an area here to work on with her. For lunch, could you imagine, look at this. Breakfast is at 6 o'clock and lunch is at 1 o'clock. Too many hours and later on. But her lunch is usually at a restaurant. She usually has a salad and a hamburger most days of the week, and she purchases them mostly at a fast food restaurant like McDonald's, Jack in the Box, Burger King, Del Taco. I don't know if you have those other ones here, but I know you have McDonald's because that's all over the world. And she says that she does eat at a sit-down restaurant once a week, Olive Garden, Mimi's Cafe, Red Lobster. Those are the few of the restaurants that we have. But look at this. If she does not have enough time to eat, she has a candy bar. Oh dear. Now, as a dietitian, when you're interviewing your patient and you're writing this down, you know, your own thoughts come to your head, but you don't ever want to verbalize out loud your thoughts. Oh my goodness, you do what? You eat a candy bar when you can't eat lunch? You don't want to be doing that because you don't want to discourage them, or you don't want to, if they do say something positive, like, wow, you have a salad? That's fantastic. Then they might be tempted to just only say the good things, report the good things to you, because they like it that you're praising them. And which we should, you know, but for the time that you are gathering information, stay as neutral as you possibly can. Now, dinner is 6:30 at night, and you already know about this. She cooks dinner about 3 to 4 times a week. Her husband prepares dinner a couple times a week, or they eat out. Now, the dietitian and the student dietitian that spoke with this patient continued to ask her, well, what about your food purchases and preparation for meals? What do you do for that? So the patient claims that she goes out to the supermarket once or twice a week to buy the groceries. But she makes sure that these are foods that are processed, that don't really require any cooking at all. The only thing that she wants to do with the food is that she just wants to heat it up. She doesn't want to have to cut things up, season this, season that. She doesn't want to bother with all that. She just wants to take it out of the package, heat it up, and put it on the table. So, this is the 24-hour recall that was obtained from her. But unfortunately, this 24-hour recall that they obtained from her was the day before she went into the hospital, and this was the time that she wasn't feeling well. So, as usual, at 6 o'clock in the morning, she had one piece of whole wheat toast. Oh, that's a good thing, whole wheat toast. It's better than white. And she did have 12 ounces of black coffee. 12 ounces, a cup and a half. And then she had a late lunch at 2 o'clock. She had half of a chicken Caesar salad from McDonald's and more coffee. Interesting. But then dinner time, I believe that, you know, she did the thing that you and I would do if we were feeling nauseated and if we had strong stomach pains. We really wouldn't want to eat. So she skipped dinner altogether that night. So this isn't really a good reflection of how she really typically normally eats. So her nutritional needs, the dietitian and student dietitian estimated that her caloric needs usually for the day is about 2,100 calories, but for that day she only met 9.19% of her estimated nutritional needs. And for her protein needs, they estimated for her that she needs about 52 grams of protein per day, so that's less than 1 gram per kilogram of her weight. Okay, and for that day though, she only consumed about 38.9% of her estimated nutritional needs. So that day she just was not eating well. And in the past, these are the diets that she has actually been on herself. Atkins diet. Oh, big gasp. I know you're just mortified. Oh dear, how could she? And then prior to being on the Atkins diet, oh wait, before I go to the next one, everybody here is familiar with the Atkins diet? Yeah, okay. I'd be interested to know what your thoughts on that are. Not very good. Okay, good answer. And prior to being on the Atkins diet, she was on the Jenny Craig diet. Okay, a little bit better than the Atkins diet, a little bit better. Okay, it's somewhat more balanced in a way, but doesn't it make you think and wonder if she was diagnosed at 16 years old, shouldn't she have known about the diabetic diet? And shouldn't have that been part of her diet history, that she should have been trying to follow a diabetic diet? I would have asked her that, but I wasn't there to ask her. But I would have been curious. Didn't you even try? Why did you have to do all these other ones? But see, her weight was fine, so I'm not quite sure why she did the Atkins diet or the Jenny Craig diet, and there was no history reported that she had lost weight, unless they didn't go into that with her. Okay, so then, let's go back in time a little bit. So from July 26 to August 2, she was in the hospital for diabetic ketoacidosis. Prior to that, the year before, for just a couple days, she was admitted into the emergency department with very high blood sugars. And then prior to that, from August 2 to 13, 2009, she was admitted for pyelonephritis. And pyelonephritis is a kidney infection, okay? And then earlier, she was admitted to the emergency department for vomiting. So it's like, there are issues here with being admitted for vomiting and vomiting again prior to that in January 6th, a few months before this last one. And then December 20 to 20 in 2007, abdominal pain. I think there was one more here. July 1, 2007, she went to the emergency department vomiting as well, and then June 4, 2007, she was admitted for right leg cellulitis. But if you can see this history of vomiting, abdominal pain, vomiting, high blood sugars, you know that those are symptoms of diabetic ketoacidosis, having that vomiting and nausea. And so wasn't someone helping her along the way and guiding her along the way? Wasn't she listening? Sometimes it makes you wonder. Or maybe she just got used to it and was thinking, well, I'm just going through the motions once again. Now, okay, so we went over this already. The etiology usually of diabetic ketoacidosis is that it's because inadequate administration of insulin, an infection, having a heart attack. And it usually occurs in type 1 diabetes, but it doesn't mean that those with type 2 can't. But most often, it will happen in type 1. Just looking at my time. So when she was being interviewed by the dietitian and the dietetic student, the patient had abdominal pain, was nauseated, appeared slightly fatigued, but had no apparent signs of distress. But she was very willing, the patient was very willing to talk to the dietitian and to the student. Medications. She was on several medications. We have here Elavil, which is an antidepressant, anti-anxiety medication. She was on Norvasc, which is a blood pressure medication, And if we go down, she was also on another blood pressure medication, which is low pressor. And you'll notice that a lot of patients in the hospital many of them are on either 2 or 3 blood pressure medications. And I really think that if we can continue to be educating our patients on, you know, our healthy lifestyle through diet, through eating well, through exercise, that we can help them get off so many multiple medications. Now back up to Soma, that's the skeletal muscle relaxant. She was on Lortab, which is a pain medication, and Lantus, which is an insulin for her diabetes, of course. She was on Levaquin, which is an antibiotic. There's our low pressor, our blood pressure medication. And she was on Lovastatin, a lipid-lowering medication, and another insulin called Novolog. As a dietitian, it is so important to know your medications well. Because like if you look at Lovastatin, it's also our responsibility to also educate your patient on food and drug interaction as you're going in to talk to them, just to do your interview, like your initial assessment interview. It won't hurt to say, oh, you know, by the way, you might already know this, but you know that there's a relationship between grapefruit and the lipid-lowering medication that you're on. And so that's one thing I really drive home with a lot of our students, and is to know your medications well. Not that you have to know it to a complete detail, but at least know what it does and if there are any food and drug interactions with them. Moving right along. So when the patient came in on the 26th, her blood pressure was at 204 over 102, and normal range is around 120 over 80. Her blood sugars, when she came in, was 822, really high. By the time she left, it went down to 187. And usually when they're in the hospital, we're just really thankful that their blood sugars, if we can get it down to less than 200. You know, with all the situations going on in the hospital, they feel so stressed being there. It's somewhat hard to control their blood sugars. It just goes up even though you're really doing your best. But less than 200, we get really thankful. But we would love to see it anywhere between 70 to 130. And they tested her for acetone, which is what? A ketone, and she tested positive for that. And by the time she had left, they actually didn't test for that again. Her BUN and creatinine were both high at the beginning, and so that's probably why they thought that she had acute renal insufficiency. But then by the time she left, they were down to normal. Her sodium was really low, and remember, you know, I was going to say dehydration is one of the symptoms or the side effects of having diabetic ketoacidosis. And dehydration, you really should have a high sodium, but in her case, it was low when she came in. It's one of those exceptions, but by the time she left, it was normal. Her potassium stayed normal throughout. Chloride was fine. Her CO2, they were both normal throughout, but usually CO2 levels could be abnormal during DKA, and they did not have an albumin level when she came in, but by the time she left, it was 3.3, so just a little bit below what we'd like to see it. Okay, labs are so important to look at, like albumin, that's a protein marker, one of the many that we would like to look at, but that's the one that's usually available in a hospital setting. And we would like to see other ones that tend to be more expensive. But while she was in the hospital, on July 27, her diet order in the hospital was a diabetic diet. And in the hospital, we make sure that they ordered the right amount of calories for them. Because if they are being given too many calories for their height, their weight, and they eat everything that's off their trays, that can also make their blood sugars go up. So she was on a diabetic diet, but the next day, I believe she had problems with having abdominal pain and was throwing up once again. So they thought, you know what, let's just not feed her for the time being. So they made her NPO, which is nil per os in Latin. That means nothing. It means nothing by mouth. And so they were just waiting to see if things would calm down. And then later on that day, they thought, let's see if she can try some clear liquids. And so they tried that. At my hospital, at Loma Linda, we have a diabetic clear diet. So I don't know if at this hospital, if they differentiated that there. And then July 31, they put her back on a diabetic diet. So it looks like they had her on a clear liquid diet for almost 3 days. So she must have been really having issues with the nausea and throwing up and vomiting, excuse me. But by July 31, she was able to eat solid food, which is a good thing. But while she was there, this is how they took care of her. They gave her IV fluids, and usually with diabetic ketoacidosis, that's what you do. You have to be put on IV fluids so that the patient will be hydrated back to the status where they need to be at. And so the fluid that was being given to them contained the appropriate amount of potassium and sodium. And of course, she was being given insulin. You need that insulin to stop that diabetic ketoacidosis process from happening. So they were giving her that insulin that she really needed. And of course, while she's in the hospital, they were giving her the appropriate diabetic diet. And when she was in there, I believe that the diabetic nurse educator reviewed with her self-monitoring blood glucose, or they were reviewing with her how important it is to take your own blood sugar levels every single day and throughout the day. And I know that the dietitian and the dietetic student were going over that with her as well. And even though she's had diabetes for all of these years, it doesn't hurt to go over the diabetic diet once again with the patient. And by this time, you know, we usually ask them, we would love to go over the diet with you one more time if that's okay. A lot of times they will say, you know what, I already know what I'm doing. That's all right, thank you, just give me the paperwork. And so you actually have to just respect that and say, okay, not a problem, but then you would have to document that you attempted to review the diet with them. But with her, they were able to review the diet, and they specifically did carbohydrate counting with her, as well as go over the plate method. And we'll go over that once again tomorrow, Thursday. And they also gave her written guidelines to go home with. Okay, so they gave her all that education while she was in the hospital once again, and they reviewed with her what DKA is, diabetic ketoacidosis, and the signs and symptoms. The outcomes, thank God, that the DKA was resolved, her blood pressure was resolved, it was improved, those abnormal lab values went back to normal, her weight was maintained, she was more willing this time to make necessary nutritional changes and receptive to information. And sometimes though, like maybe this time, because it was really serious, really severe, sometimes those are the times that they really wake up and say, okay, I am going to follow what you have to tell me. I've heard it before, but this time I will do it. The patient was able to verbalize understanding of nutritional concepts, and she was willing to attend classes in diabetes outpatient center. So it sounds like their hospital also has an outpatient center that's specific for diabetes, and there is a dietitian that works there too, just like Loma does. So we have that as well. So when our patients are diagnosed with diabetes in the hospital, not only do we educate them on their diabetes in the hospital, but then we say, you know what, we will send you to the outpatient clinic to get more education from the nurse, from the other dietitian on more detail. So it's a good thing that her DKA was resolved. Otherwise, what happens when DKA, diabetic ketoacidosis, just keeps going and it's not treated? What can eventually happen to the patient? They can die. That's the most serious result. We don't want that to happen for them. But the thing that we have to realize is that a one-time education might help. Oh, you know, one-time teaching might be helpful for some people who are already motivated from the beginning. But you have different personalities, different types of patients out there with different levels of motivation. And sometimes they won't care for so many years. They'll say, oh, I can just live with this. I want to live the way I want, eat what I want, when I want, as much as I want. But then sometimes later on, don't give up on them. And don't get discouraged if I've gone over this with them so many times before. Is it going to make a difference this 10th time? You never know, because sometimes it actually does later on. Don't get discouraged that not every patient is the same. I've had patients where, oh, the first time you talk to them, they are just listening to your every word. And then don't be discouraged if you have some that will just nod and say, oh, that's nice, thank you for the information. They may not be as animated in their thankfulness to you, but just know that they are thankful. And some won't follow you initially because they might be in a stage of denial, but that's okay. Later on, they will come back and they'll say, you know what? Okay, I've accepted that I have this condition, but I can live with it because I've been giving the tools to live healthy with this particular medical condition that I have. But we do make a big difference. And even though I don't know what the result of this patient is, it's been a year, I hope and pray that she's doing well, but I just have a feeling that, you know what, she has been taking things a little bit more seriously, because being in the hospital that many times and ending in so much pain, you don't want to be there again. And so don't give up. Be part of the nutrition team when they're in the hospital. Make sure they're getting the appropriate diet, and make sure that they are getting what they like to eat too, because that helps with while they're in the hospital. Sometimes they get food that they're not used to eating, but if we do our job to facilitate the food items that they do like, that can help while they're in the hospital too. And when they realize that, wow, this is the way that I can eat, how they're feeding me here in the hospital, I can do this when I go home, well then it makes it more doable and more user-friendly for them. So that's the case study for the day. We have another one for tomorrow.